Okay, as I enter the room for my assessment, I will verify HIPAA with the patient, ensure privacy, perform hand hygiene, check that the bed is in a locked position. While doing this, I get a sense of whether or not what the patient's level of consciousness is, ask them for their reason for their visit today, confirm any allergies. I'll raise the bed to a working height, and then I will begin in the scalp assessing for normal hair distribution, any bumps or lymph node swelling. Then I move into a assessment of cranial nerves with the pen light, have them follow it with their eyes in order to assess all of the cranial nerves relating to eye movement, assess for accommodation and perla, have them close their one nostril and blow to assess patency of the nares, and then do the same on the other side. Also visually inspect their ear canals by having them turn their head. All right, and then I'll have them open their mouth. I'll assess the teeth and anything in the throat that I can visualize, uvula rising to midline. Coming down to the neck, we can assess the carotid pulse with the bell of the stethoscope. Don't want to include on both sides at the same time. Can also assess their thyroid by having them swallow. Then moving down to the chest, we use the diaphragm of the stethoscope, and we can listen for lung sounds, having the patient take a deep breath in and out in each spot. Go down, assess all the lobes of the lung, and on the sides, you can assess the back of the lung once the patient is risen, but from here, you would assess the 5 points for heart sounds, including Erb's point with the bell. And then at the apical pulse, ideally you'll listen for a full 60 seconds. You can compare that to the peripheral pulse. From here, I like to move down into the vowel sounds, listen for all 4 quadrants. You want to be able to hear vowel sounds within 30 seconds of placing the stethoscope. After that, we can palpate the vowels. Again, we want it to be soft and no guarding, no pain, that sort of thing. Then I can come up to the arms and assess strength and reflexes, have them push against, pull back, shrug their shoulders against resistance, all that sort of thing. Then moving down to the legs, we can have them raise up, and ideally I would be able to see the leg, visually inspecting for any wounds or edema, any sort of abnormalities. While it's up, you can have them do passive range of motion, moving their ankle in every direction. Great, and you do that on both sides. And coming down to the feet, have them push against resistance, pull against resistance, assess pedal pulses. They should be just as strong and in line with the peripheral and carotid pulses. Next, we'll have her rise to a sitting position. She should be able to do this within her own power. Coming to the back of the lungs, we can listen to lung sounds back here as well. Same way that we did on the other side. In this position, you can also test for lung expansion. You want to see that move. At some point in this, you can be just assessing passively for respiratory rate. From here, she can also move her neck forward toward her chest and back and side to side, assessing range of motion of the neck. And then, as long as she's comfortable, she can rise to a standing position and do the same sort of assessment at the base of of the spine for the lumbar. Great. And then I'll have her walk a few steps and come back to observe her gait. And that looks normal and even. Then I'll have her return to her original position of comfort. Make sure that the call light is in reach and everything is available. Reporting normal findings through this to reassure the patient. If there's any sort of specific problem, you get into a more problem-focused assessment. But otherwise, is there anything I can do for you right now?
That was pretty thorough. Thank you, Nurse Dakota.
Perfect.